Good morning, everyone. We're just going to wait for everyone to join us, but we will get started here in 1 second. Okay, so good morning and welcome to our webinar, The Year of the PA, New Laws and Changes to Practice. We have a panel of experts today from the WMC as well as WAPA to present some important updates and answer your questions. We encourage you to ask those questions throughout the presentation by using the chat box within Teams, and we will do our best to address those questions at the end of the presentation. We are recording this webinar and it'll be available on our website within the next few days. So please feel free to share these resources with your friends and colleagues who couldn't be here today. So with that out of the way, I'm going to turn this presentation over to Micah Matthews.
Thanks, Jimmy. For everyone who's on the call, my name is Micah Matthews. I'm the Deputy Executive and Legislative Director for the Washington Medical Commission. Welcome to this joint webinar between the WMC and WAPA. For WAPA, Paul Surratt will be representing them, and then we've got a phone a friend in the form of Chelsea Hager, the contract lobbyist for WAPA in this past session. So with that, we'll move right along. Maybe. Paul?
Hi, thank you. Thank you for having us. My name is Paul Surratt. I'm a practicing physician assistant in Washington and a member of WAPA and also the legislative committee chair. So a little bit of background about WAPA. WAPA is the Washington Academy of Physician Assistants. We represent the more than 4,500 PAs across Washington state. And we provide support for PAs with a number of services, including job search, among others. WAPA is active on social media and through their member newsletter. And there are the following handles and usernames for our social media. So please feel free to engage with us there.
And as far as the Medical Commission, just as an overview there, we are the regulator for physicians and physician assistants, and as of this legislative session, certified anesthesiologist assistants, which hopefully we will be launching that profession for licensure in the early part of 2025. So the Medical Commission is a group of governor appointees, 21 members. As you can see, the breakdown there, the physician, physician assistant, and public members. And as far as about the WMC, we were founded in Article 20 of the state constitution. Currently, we've got about 36,000 licensees, 5,500 of which are PAs. We have 62 staff of various classifications ranging from customer service to professionals such as physicians or lawyers. And we have a $27 million biennium budget. So jumping right into the bills, the first one is the PA Compact. And so this one flew through the legislature and was adopted pretty early on, thanks to Senator Mazzal and Representative Mari Levitt, who were the prime sponsors of the respective bills in their houses. And so what it does, it does allow the Medical Commission to join the PA Compact. We were anticipating that it wasn't going to go live this year, and surprise, in May it activated and more states are joining. So what that means as far as a timeline I'll get to, but just to cover the basics of a compact, it is a federally recognized agreement between states. And so if you're not familiar with compacts, let me assure you that you participate in them as a member of the public. The driver's license compact, the tax compact, Columbia Gorge compact. If you've ever driven across a bridge going from Oregon to Washington, you have probably benefited from a compact. And so they historically have not been used for license mobility or healthcare regulation. That's kind of been a newer thing, and the nursing profession is probably the one that most people are familiar with and has been the most long-standing. However, I think it's possible that the medical license compact is now the most successful health profession compact in the United States at this point, with 41 members, with Florida being the most recent to join, although they are not issuing licenses at this point. So it's a recognized agreement between states. It's recognized in federal law. And importantly, when there are conflicts with state law, the compact will supersede to the extent of that conflict. It just makes things a lot cleaner. But in the context of health profession context, one of the key things to remember is most compacts are written to respect the State Practice Act. So they typically do not deal with scope. They don't deal with the specifics of Practice Act and the things that legislators and policymakers like to put in as far as a state-specific concern. So generally, it's just about facilitating license portability and mobility. So with respect to the PA Compact, it is a privilege to practice model. And what that means is you have a license in one state. If you qualify to get into the compact, you will ask for a privilege to practice in that state. While from a regulatory standpoint, it sounds a little bit different, we're really treating that privilege as a license effectively. So we do plan on issuing a privilege document. And so that's actually in line with the PT Compact, which was passed a few years ago, and they do the same thing. They issue a privilege document saying you have a privilege to practice in Washington. So that's really where we're going with that. The timeline at this point, and I'm going off of council state governments for standing up the compact, who they're sort of the base organizers at this point for standing up the compact, and they've stood up dozens of compacts. So they generally say 18 months from the initiation or activation of the compact. And so at this point, we have been contacted to start selecting who our designee will be for the compact as far as the state official. And so I'll just say right now that we have selected Marissa Courtney as our licensing manager, and she will be the one that will be our representative to the compact. There will be probably a few preliminary meetings. Most of them will occur in Washington, D.C. Usually, council state governments, because they have this location called the Hall of States, and it's a large building, but not limitless with respect to attendance. So usually, if there are interested parties, they will stream these sorts of things so that people can observe. There is some open public meeting and Administrative Procedures Act requirements that they have to adhere to with respect to doing their meetings, rulemaking, elections, and that sort of thing. And it's all pretty standard when it comes to that. So we anticipate that at the end of the 18-month timeframes kicking off in May of this year, that we should be up and running with respect to the compact and hopefully issuing those compact privileges. Over to you, Paul.
All right, I'll talk to you a little bit about the PA Collaborative Practice Bill. This was House Bill 2041, and it just passed in this last 2024 legislative session. So essentially what this bill does is it replaces the supervision model with a collaborative practice model for experienced PAs, and it creates a tiered pipeline to collaboration. So under this model, supervised PAs are PAs who have under 4,000 hours of postgraduate clinical practice and 2,000 hours of specialty practice. And for the first 2,000 hours after switching to a new specialty, PA would be under the supervision. PAs who are considered under the collaborative model are PAs who meet the requirements above. And we define this as being able to interact with, consult with, or refer to a physician or other appropriate member of the healthcare team as indicated by the patient's condition, the education, experience, and competencies of the physician assistant, and the standard of care. So looking a little bit more into this, the PA scope of practice essentially mirrors the participating physicians or the group of physicians that the PA is working with in that specialty area or department. There is an exception to this, however. So PAs, if they are practicing in a medically underserved or rural area, if they have over 10 years or 20,000 hours of specialty experience, they can continue to work outside the specialty of their participating physicians if they continue to obtain CME in that specialty. That, however, does need to be described in the collaboration agreement. So all PAs will sign a collaborative agreement rather than a practice agreement. This eliminates the medical commission's role in the agreement approval and collection process. The collaborative agreement can be signed by participating physician or the PA employer, like a medical director. One nice thing about this for PAs as well is that it removes the physician to PA ratio, as well as authorizes direct pay and reimbursement for PA provided care. Maybe also of interest to all of you to know that it removes the physician liability for the care provided by PAs, and that PAs are legally responsible for their own medical decisions.
So Paul, I'll just jump in on one thing to clarify. On point 3, the signatories to the collaborative agreement I just want to emphasize that not the PA, but the person supervising or collaborating, they have to be a clinician. It can't be, the clinic manager or something, a non-clinician. It has to be a clinician that signs that. So that's no change from before, but just wanted to clarify for folks that requirement still exists. Yeah. So with respect to implementing the PA collaboration bill, we've got a few things going on. So we did pass the WMC did adopt a request for rulemaking, and so we've got that in process. The rulemaking is pretty limited, frankly. So we are trying to do it in an expedited process because they're not substantial changes. The rulemaking is limited to striking instances where it says practice agreement and changing it to collaborative agreement. And then we are adding 2 definitions that were in the statute or in the bill that was passed. And so there's not really anything substantial in the rulemaking that's changing. So it's just an update. So we're using a process called, I believe, the 105P process. And that allows us to do an expedited rulemaking to quickly get this in place. And as of last night, I believe our practice agreement portal was deactivated, so you can no longer fill out practice agreements on the web. We have the model collaborative agreement PDF in its place. You are more than welcome as a PA or a clinic to make use of that. However, you don't have to. It's a model suggested agreement, but it's something that we would be looking for. And I want to point out and thank WAPA for their collaboration in developing that model agreement and getting their feedback from their members. And then in October, we do anticipate that the expedited rules should be finalized. And so this part may be a little bit confusing. So July 1, 2025, or your next renewal, whichever is longer, all PAs need to be converting from their practice agreement to their collaboration agreement. So there is some work involved for licensed PAs, but it doesn't formally kick in until July 1, 2025, or your next renewal, whichever is longer for you. And that appears to be it.
Well, I hope everyone will thank the panel with a virtual round of applause. We really appreciate this expertise. Go ahead and take a moment. If you have a question, type it into the chat. This is the time to get clarification or ask any questions about this change in practice. So well, I'm going to give people a moment to type in their questions. So just to be clear, when you fill out if you follow the model practice agreement that's on the WMC website, and then what happens next? You sign it, the physician signs it, and then what happens? Can you give us a little more detail about that?
Sure. So the law says that it will be kept at the practice level. So what you need to do is keep it on file. So really, what we're doing here with respect to the change is taking what was originally an employment agreement and putting it at the place of employment. So I can't speak to the history of why the medical commission ended up with the approval responsibilities, other than in this state in the 1970s, when the profession was stood up and licensed, it was probably an aspect of it was a new profession to regulation in this state, and so there was more oversight just based off a lack of knowledge and history for the regulator. So since the 70s, I think we've seen some pretty compelling evidence, both in this state with lack of discipline, but also there's been a number of national studies that show the efficacy and safety of PAs, and that's, I think, gone a long way, along with the elevation of training standards and education standards to more liberalize the practice and as far as the regulatory aspect of it.
Okay, so then we have two questions on the PA compact. One, would a PA coming to Washington on a compact privilege to practice eventually need a Washington license? And I'll read the second one after.
Yes and no. So if you are coming to Washington and you've got that privilege to practice and you don't intend to relocate to Washington, you're just and you don't want to redesignate yourself if you're not relocating to Washington, then no, you're not going to need a license. To that privilege to practice is what you need through the compact. If you were to move to Washington, it would probably be advisable to switch over and just redesignate yourself to that Washington designation, that's where you reside and that's where your license would be. So you could, at that point, you could probably swap over. There is some uncertainty on that, I will just go ahead and say, because there are going to be some rules that the Compact Commission will adopt, and they might further define that. And then the second question, will WMC require additional staff to administer the compact? Yes. We are going to learn our lesson from the medical licensure compact, which we always enjoy telling the story. When we initially estimated the impact of the medical licensure compact, we thought maybe we would get 70 additional applications per year. There was no precedent. There was nothing to compare against. And we launched in 2017. I think we've issued somewhere close to 4,000 compact licenses. And so, luckily we were able to designate one staffer as the compact specialist, and so that's helped us get those things sorted out. With the PA compact, we anticipated that it would probably go live, and so the session before last, we did a decision package to request for staff. One of those staff is going to be designated at least half-time to be the PA compact specialist. So it's already in process, and we anticipate that we will be able to cover the workload.
And then we have a question going back to the collaborative agreement. If there is a new physician supervisor in the meantime, how do the PAs make this change if the portal is deactivated?
We've got the model collaborative agreement already in a PDF format on the website, and I think we can probably drop a link to that in the chat so everyone will have it. And so just you can just make that update there and have that on file at your place of employment.
And how does a clinic move PAs from their current to new agreements?
Well, the timeline, as we said, was July 1, 2025, or your renewal, whichever is longer. So there's nothing that says you have to convert right now. If you have a chance, if you have time, you can certainly do that. But that's the timeline as far as July 1 or your renewal, whichever is longer. So as I said, with the collaborative agreement, it's on our website right now as the model, and it's just a PDF that you can complete, or your clinic may choose to adopt something of their own.
So then do the PAs have to do the new agreements themselves?
Paul?
I think that's really going to depend on your employer. I know in some practice settings, PAs are going to be probably seeking out to speak with their clinics and their medical directors about getting this updated to collaborative model. Whereas other clinics may have some standards that that's just going to vary from site to site. So from a procedural standpoint, but when PAs are up for renewal, it's certainly something that that both the PA and the employer should be looking at. Is just somebody that can switch over to a collaborative practice model.
So then will a PA who does not yet meet the criteria for collaboration remain on a practice agreement?
And for this one, I'm going to phone a friend because I'm not sure my interpretation is right on this. So Chelsea, could you pop in and provide your input here?
So the law is drafted in a way that allows for everyone to use a collaboration agreement, regardless of whether they have met that 4,000 hours of postgraduate clinical practice and the 2,000 hours in the specialty that they're working in. So everyone should work towards converting to the collaboration agreement. Either now that it's uploaded online or before you renew, but the trigger is really whether that PA has met that threshold of the 4,000 and the 2,000 hours. So once that's met, the document itself isn't as important as the fact that the PA has reached that experience threshold. Does that answer the question?
It does from my perspective.
Okay.
I'm hoping it does for Liz Dean as well.
Please feel free to follow up if you've got another question.
So then we have a scenario for you. I'm a PA and my next renewal is in 2026. Does this mean I need to have a supervising physician until 2026 since this is when I'm due to renew?
And I'll kick it to Chelsea on that one again if she'd like.
Just rereading the question one more time. So you don't need to have a supervising physician any longer than once you reach your requirement for the 4,000 hours of postgraduate clinical practice and 2,000 hours in your specialty. So if you are working with a supervising physician right now, the law requires you to start tracking your hours, and you will be attesting to that number of hours in the future when you sign a collaboration agreement. That's a new requirement, is that the PA will be tracking their hours. And so you should notify your supervising physician when you're approaching that threshold and let them know that your relationship with them is going to be changing pursuant to this new law. And therefore, once you reach that hours threshold, they will become your participating physician and you will be working in collaboration with them, and have the opportunity to work in collaboration with others on the team. The kind of the crux of this law is simply you need at least one physician that you are that is your participating physician you're working in collaboration with, and you can go to others depending on what the patient needs. So it's intended to provide some flexibility, but really the trigger here is the number of hours.
And I think we answered Eddie Cole's question with Chelsea's response.
And I'll just read it for the recording for folks who view this later. So who is responsible to track the criteria for where they are in their hours? And it was responded that the PA is responsible for tracking and attesting to their number of clinical hours when they sign the collaboration agreement. So then we are asked, are there changes in PA scope regarding supervision of another clinician? For example, under the new collaboration model, can they supervise licensed providers such as medical residents or ARMP providers?
I don't see any change it's just not addressed. I don't see a scenario where clinically a PA could supervise an ARNP and vice versa. Maybe from an HR standpoint that might occur in some clinics, but as far as giving clinical direction, both PA and ARNP, I don't see where that would exist in the law.
And then do these clinical hours start when they're initially licensed?
They're tied to practice. So if you have been licensed but aren't practicing, you're not counting hours. It's about time on station doing the clinical work.
So as a site administrator, what agreements are required for PAs that have greater than 4,000 hours? And what is the difference between, what's the difference that needs to be signed for greater than 4,000 hours and less than 4,000 hours?
I'm trying to make sure I understand that question. So at this point, we've got the collaboration, the model collaboration agreement. And as Chelsea was stating, it's going to be the same whether you are under the 4,000 hours from postgraduate or under 2,000 hours from working in a specialty or switching. And so it's the same form, and you would simply just be notating, what model they're at based off the number of hours that the PA tracks.
What is acceptable documentation of these hours? Is it just an attestation, or do you need case logs? And in addition, will the WMC audit the proof of hours as is done randomly for CME?
Currently, we're relying on the attestation model, just like CME. There is not a plan to audit anything at this point. This is a new requirement, so just bear in mind, what we're trying to do is at least stand up the model and get the rules in place, so at least there's some stability and structure there. I can't say that we won't ever audit. My guess is what might happen is if someone lets their license expire or lapse, there might be a request to send in your verification. If there's a complaint or a question on a PA in that process about how many hours have they worked or something like that, there could certainly be a request for them to produce documentation by the commission in the process of that investigation. And that's fairly standard. If we get a complaint that someone has not completed their CME, a standard part of the process of investigation is produce your CME certificates and everything else just to validate what you've done and what you haven't, or if you haven't done anything at all.
So are PAs now considered to be LIPs in the state of Washington?
I'm not totally clear what LIP is.
I assume it's licensed independent provider.
PAs have been considered autonomous providers for a while, and they are also recognized in the federal code that way, and which is what allows them to bill and do various functions. I'm not sure I would classify it as independence. There is still an aspect of collaboration and being attached to a physician, but I'll certainly open that up to Paul and Chelsea for their interpretation.
Mike, I would echo what you said there regarding the recognition of PAs being autonomous providers, and in certain situations might be the only provider that or clinician that a patient sees. However, there is, and was intentionally so, still a connection to a physician required under the law. That was where the legislature was with what they were comfortable with this year. And so I would not say that PAs are independent as a result of the law. I think the one caveat to that, or I guess one point I would make, is that those PAs that are working, that have been recognized as working in a medically underserved or rural area, are getting CME in a specialty where they've gotten over 10,000, 20,000 hours or 10 years of experience, are able to work outside the scope of practice of their participating physician or physicians. And that sometimes can be seen as independence, but that still is required to be described on their collaboration agreement. So not fully independent, but certainly autonomous.
And once on a collaboration agreement, do all participating physicians need to be listed on that agreement or just one main participating physician?
Chelsea?
Just one needs to be provided. One of the goals of this bill was to try and make it a little bit easier for PAs to practice. So to ensure that they always have at least one physician to go to should they have a question or the patient requires an additional set of eyes or input, but to allow a PA to go to other clinicians as appropriate. And so only one needs to be listed. And on the model agreement that I think is going to be shared in the chat here, you can see where there's a spot for that person to indicate who they are. And I actually want to take this moment to clarify something that was mentioned earlier. A physician does need to be a signatory on this agreement. So the scope appropriate person, like a medical director, could be that physician. That's something that we changed with this bill because we wanted to provide more flexibility. So a physician does need to sign it, but they don't necessarily, it doesn't need to be the participating physician. The participating physician simply needs to be made aware of the fact they're being listed and to have an opportunity to object if they want to. So for example, a medical director who's a physician could sign the agreement with the PA, list another participating physician's name, as long as they're notifying them and they're agreeing to it. Which will hopefully speed up the process on the administrative side.
So we have another scenario for you. So if a new but experienced PA, say 15 to 20 years in practice, was just hired and signed a practice agreement, when will the new rules go into effect for them? Should they just complete the model collaborative agreement now, or will it go into effect July 2025?
Micah, my understanding is that it goes into effect January 2025 for them.
I believe that's my understanding as well.
So you're almost there.
Yeah.
But should they just do the new collaborative agreement now, or should they wait? What's best practices?
I mean, because that particular piece of the law goes into effect in January, I would suggest waiting to do that until then, or you could do the collaborative agreement now and note that new model will start for them in January. So again, flexibility was the goal throughout this whole process.
Is there any liability held with the physician collaborator under the new collaboration, or does this help to free them of this if the PA is sued or something else happens?
I'm going to phone a lawyer on this one, Chelsea.
Happy to jump in here. And this one is a little bit complicated, and the bill changed through the process. So the bill that was initially introduced on this topic didn't reflect the way in which it looked at the end. So the goal with the initial language here was to try and reduce the physician liability in an effort to encourage physicians to want to collaborate with PAs. We initially had some language in the bill that said that the PA has sole professional and personal responsibility for the care that they provide. The word sole was an issue for the Washington State Association for Justice, the trial attorneys, because they found or felt that it would put PAs in a different position than other clinicians, and because it would disallow a PA and their hospital, for example, from being sued if there was contributory negligence from the hospital for against the plaintiff. And so ultimately what ended up happening with the language is that it says that it no longer references there being physician liability. It does say the PA is responsible for the care that they provide. However, similar to other clinicians, the statute now reflects a reality where it would be possible for a attorney to name a physician who might be the PA employer or a hospital system in a lawsuit if they deem it to be appropriate. So it's a reduction in liability, I'll say that, because it no longer says that the PA and the physician each retain the liability or responsibility. It now just says that the PA does.
Okay, so one more time for concrete understanding. All physician assistants are now permitted to sign the collaborative agreement. However, that agreement will not take effect until January 1st, 2025.
Chelsea, correct me if I'm wrong. I think we were talking about the 20,000 hours part. Was that what you were talking about, January?
Yeah, so essentially the PA is able to start working, PAs can start working in collaboration as of January. They have a little bit more time to transition over to that collaborative agreement model, and should go to the website in the meantime and make sure that they are aware of what sort of parameters are around what collaboration looks like. It's a really exhaustive document that explains what you should and should not do. But you do have until July to start transitioning over to that document or upon your next renewal.
Right. And sorry, go ahead.
Oh no, if you have a follow-up to that question.
No, I was just jumping to the next one.
So if we're not responsible to keep a copy of the collaborative agreement, how does a PA know if one has been filed? Are we to assume that you have it?
So I'll go with what I think I see on that question. You are responsible for keeping the collaboration agreement. But the thing is, it's supposed to be at the practice level and not filed with the commission, because that was the model that we had, which is you just had to file it. We didn't have to approve it, and before we had to approve it. So now it's transitioned to where it's just between you and the place of employment or where your practice is. It needs to be kept on file there. I would advise that if you do have one of those and you're a PA, you should probably keep a copy of it for your own personal records and not just keep it at the employer. Let the employer have their copy, but at least have one for reference for you and your files. That's just, that way you have a point in time document that documents everything that you agreed to. So that's, to me, that's just a best practice.
So I think there's still some confusion in terms of the timeline for when this collaboration agreement has to take place, because I'm going to just try and phrase this all in a different way. Hopefully it's a little more clear. So as of today, the practice agreement portal on the WMC website is gone. So if you are hired by a new physician tomorrow, what does that PA and physician need to do?
They can either use the collaboration agreement that is now on the website as a model that we're providing, or they can come up with something of their own that meets the requirements in the law. And Chelsea, I'm going to ask you to kick in here if I get something wrong. The collaboration model starts January 2025. However, the current collaboration agreement will still satisfy the requirement for having supervised practice and that sort of thing. So you can still use the current collaboration model. It's the same document. It will be the same document in January 2025 and July 2025. And we're hoping we're not going to have any tweaks to that. But the important thing is, if you were hired today and you needed to complete an agreement, this collaboration agreement will satisfy the requirement that you need, because you will still be under that supervision practice agreement model until January. So you can write the collaborative agreement to address current state and what will happen starting in January. And keep it on file at your employer and not send it to the commission, please.
And then just for clarification, one more time, what happens in January?
January is when the collaboration model of practice comes into effect. And so that's the earliest it happens. So if you're on that 4,000 hours, if you're on the 2,000 hours, and you can move into the collaboration model where you just have a participating physician and not a supervising physician, that is where the trigger is. Everyone must be converted over by July 1, 2025, or by their renewal, whichever period is longer. So we had a commenter talking about they renew in 2026. They would be able to be on whatever their existing agreement is until that time in 2026. Should they be? I would say if you have more than 4,000 hours or 2,000 hours or 10,000, or is it 10,000? Yeah, 10,000 hours. No, I'm getting that wrong. 20,000 hours. Sorry.
10 years or 20,000
10
hours.
years, 20,000 hours. I would highly recommend that come January, you would just convert it over or have something on file with your employer clarifying that you're moving to the new model starting January 1.
Also, just pointing out in January, that will be, at least as I understand, that'll be when the physician PA ratio will go away, as well as the physician liability aspect.
Mm-hmm.
And then if just in another scenario, if you stay on your current practice agreement until your next renewal, so let's say 2026, and an amendment needs to be made to the existing agreement, what should that collaboration do? What should the PA and provider do?
I would still send them to the collaboration agreement on the website unless they have a specific one at their clinic that they want to use.
If I could just add to that, the collaboration agreement actually looks pretty similar to the current practice agreements. There are a number of key changes, but for a PA that wants to go and make a change or an amendment that is in the process that Micah just described, I think it's just easiest to switch over to the collaboration agreement.
And this might be a good time to share my screen and look at the collaboration agreement that's listed on the web right now if we're amenable to that. Is it up for you all?
Yes.
All right. So this is the collaborative agreement. I'll go back and show you where you can find it. So this is the link that Jimmy dropped in the chat. It'll take you right here to your collaborative agreement. There's some explanation about where it's coming from and the timelines. It also lists out what it must do. So this is more if your clinic is going to develop their own collaborative agreement and not use the model, then it has to satisfy those 9 items per the law. And so at this point, it also talks about it has to be located at your physician assistant's primary location of practice. And going back to the document itself, it restates quite a bit from the website, just to be clear. And then we get into a description of collaboration and supervision and scope of practice. And then it's just asking the basic questions. So it's actually quite similar to what we've had in the past. And then Chelsea and Paul, feel free to jump in if you've got something you want to point out.
Micah, if we could scroll back up to where it asks the PA to attest to the number of postgraduate clinical hours.
Where is that exactly?
Oh, you were just on it.
Okay.
Scroll down just a little bit more. Okay, and then stop. So here you can see under physician assistant information, there is a new box that was not on the practice agreement, the model practice agreement, but that is on the collaboration agreement model that asks the PA to list the number of postgraduate clinical practice hours and those that they have in a chosen specialty if applicable. And this is important for those that were asking the question of what do I do between now and when the law takes effect. If you are going to use a practice agreement rather than switching over to the model agreement, you just know that this is an addition from the law that will need to be added as of the next time you renew, but is required for you. You are required to start tracking them as of January 1st.
This may be redundant, but kind of a legal question then. So I signed this practice agreement with my collaborating physician today. January 1st, it goes into effect as a collaborative model, or does there need to be new ink signed at that time, just from a legal standpoint?
I'll defer to Chelsea, but I think I've been clear that you can do the collaborative agreement now, and I guess I would call it a post dating, saying as of January 1st, this is the model that's active.
Yeah, I guess the caveat that I would add is that you do need to make sure that you're following the new law as of January 1st. And so there are a couple pieces that are in this collaboration agreement that aren't in the practice agreements, and those are delineated on that first page. So I would just make sure that you're following current law as you think about the way that you're practicing, so that you're not running afoul of what the new law is.
One of the requirements in this collaborative agreement is a termination provision. Are there minimum standards for that termination process?
One standard that was carried over from existing law into the collaborative model is that you must provide 30 days notice to terminate that agreement. So that's noted there on the document, just that you know it. But beyond what's described here, there aren't additional requirements in law.
And then I have another scenario for you. So I'm 30 years into practice with 14 years in my specialty. How does that translate into hours seen?
When we were working on developing this bill with other stakeholders, we estimated that 1 year is about 2,000 hours. It's about actually exactly 2,080 hours by our calculation, but roughly when we were working with the Medical Association and thinking through this policy, we estimated about 2,000 hours per year.
And I'll go ahead and say that the standard human resources manpower per people power calculation for hours worked per year is 2,000. So if you look at any workforce study, and that's the number they're using. And as far as that last scenario, I'm not sure if we directly answered that, but I will say that you should easily be able to, on January 1, go to the non-aligned specialty model of collaborations, so long as you meet the other requirements of being in I believe it's a rural or underserved area. And Chelsea, there's one more, I think.
The last question I'm seeing is about holding another webinar. Is there a different question you're referring to, Micah?
It was the one from Jamera Thompson. I'm 30 years into practice with 14 years in OB. How does that translate to hours seen? So in that scenario, come January 1, theoretically, they should be able to convert over to the final tier, which is absolutely new as a concept, where you don't have to have a collaborating physician that is of your same specialty, but you do have to be in a rural or underserved area.
Right, and continuing to receive CME in that area.
Right.
So, and to just be very clear, so there is an opportunity for a PA to work outside the scope or the specialty area, of their participating physician or physicians, but it is only if you are in a medically underserved or rural area, and you're getting the CME in that. So that's not an opportunity that's available for people that are working in areas that are not medically underserved or rural.
So when do the current practice, or will the current practice agreements automatically expire?
Yes.
And what date is that?
That depends. So the current practice agreements, and as we've been saying through the webinar, will expire for you either on July 1, 2025, or your next renewal, whichever is longer of those two dates. So to go back and utilize someone who said their next renewal date is 2026, your practice agreement will expire by 2026. That's one of the reasons that we've been proactive with this webinar and making the changes to the practice agreement portal, putting up the model agreement so people can have a nice long runway up to January and July and their next renewal to be able to get that collaboration agreement in place at their practice level. And Cleta asks, you can do a group practice instead of an individual. Yes, you can. We've allowed practice agreements between PAs and groups for a long time. There's no change there. This would arguably make it easier to do so.
Okay, I don't see any other questions.
There was one about did this get answered? Anything changing? No, this bill only addresses changes for PAs, and there were no changes addressed in this bill for ARNPs. And in a separate bill, ARNPs do have their titles changed, but don't ask me which order those letters go in because I don't remember it.
It's APRN. I see another question about, is it possible to get a Word version of the document?
Yeah, I think we can probably work that out.
Even a fillable PDF might be needed.
Okay. And Kai Bryant asked, do you have to wait till your renewal change to the collaboration agreements in 2026? No, you do not. The current collaboration agreement will satisfy what you need to have done up until the conversion time or the activation time of January 1, 2026, or the mandated conversion time of July 1 or your next renewal. July 1, 2026. No, 2025.
So is there a specific number of physicians to be considered a group practice that you collaborate with, or is it just more than one?
I define it as just more than one. Models that I've seen used here are large multi-specialty clinics, emergency departments, large single specialty clinics. So just those kind of things are usually what we see with group, but I mean, technically it is more than one. Then we have a joint compact collaboration agreement question. With a compact license, will the Washington collaboration model state supersede the compact state law? Well, luckily it doesn't have to. And so as I explained with healthcare compacts, they are very careful to not touch the Practice Act. So this all exists in the Practice Act. The compact is simply working to expedite licensure. So the medical license compact, think of it as TSA PreCheck. The state that is granting entry into the compact is going to validate all these things according to the requirements of the compact. And if you do it, yes, great, you're in and you get to choose what state you go to. The PA compact is going to do largely the same thing. So any supervision requirements, if they're different, let's say a Washington licensee is getting a compact privilege in Utah. Utah just, unless I misread it, Utah pretty much made PAs independent in the last 2 years. And so that would be the model that you would be delivering care into Washington, whether it be telemedicine or if you go there. With Washington, vice versa, you would have to adhere to what is currently the law and what is changing into the law starting January 1. If you were delivering telemedicine here to Washington patients, or if you were physically practicing here. So no superseding because they don't actually touch or conflict.
So does every physician in the group need to be identified and sign the agreement, or could there just be one physician identified as the participating MD and everyone else just falls under the group?
My understanding is it's the second scenario. So you have to have a participating MD. You can list everyone under the group or say it's the group. And the question from Tanya, PA compact licenses will not be available until 18 months from May 2024. Is that correct? So that's tentative, I guess is what I would say. The typical startup time for a compact that we've seen is 18 months from activation. CSG, Council of State Governments, has I mean, at this point, they've got a checklist, I'm sure, of what needs to happen to start up the compact commission, get the rules in place, get the elections and officers in line. And we're fortunate in Washington that we already have this model that was done for the physical therapists. So from our perspective, and this is really simplifying it, from the database licensure process perspective, it's effectively a copy paste of the process, because the privilege to practice piece for physical therapists will be identical to physician assistants as far as what we're issuing, how we're processing it, what we're using the database for. So once they stand up, we should be pretty easily transitioning into issuing those privileges to practice, and however they choose to categorize entry into the compact. As I described with the medical licensure compact, we reevaluate someone before they're allowed entry. I would imagine that the process is probably going to be fairly similar for the PA compact. If you want entry as an existing licensee, we will have to evaluate you against certain criteria for entry into the compact, and if it happens, we'll probably be issuing some sort of letter of qualification or something similar, and that will grant you entry into the compact, and then you'll be able to select what states that are participating that you want to go to and get a privilege to practice.
So going back to this participating MD versus the group, there's a clarifying question that so no physicians technically need to be named, just the group?
A physician still needs to be named. If we could scroll up a little bit on page 3, even if you check the box that you're filling this out for a group rather than the participating physician, you still have to list at least one participating physician's name and have them or the employer sign.
Okay, so I'm going to take this opportunity to wrap up. If there's any last thoughts that Micah, Chelsea, or Paul would have, I welcome you to share them now. Just for everyone's awareness, the PowerPoint and webinar recording will be available on our website within the next few days. I will send out an email to all attendees of this group when that is available. And all of the questions, I mean, you guys did a great job asking questions and clarifying this law. We're going to turn your questions and help others by making an FAQ that will also be available on our website. So please be on the lookout for that. But as we wrap up, any last thoughts from our panel?
I'll defer to Paul and Chelsea first.
I just wanted to say thank you for the opportunity to talk about this. We're excited that this is a bill that has passed this last legislative session, and we look forward to this easing the process for PAs practicing in Washington, hopefully making PAs more easily employed and deployed into our workforces. So thank you.
And nothing more from me. Just appreciate everybody's time today and look forward to getting the bill implemented.
And from the Medical Commission, just thanks for the collaboration with WAPA, and I would be remiss to not thank WISMA for their work and insight on this as well. As you can see, we've got a lot of things going with respect to PAs and the changes in practice. So thank you for coming to this webinar and being so engaged and asking your questions. And I appreciate the public perspective and engagements that we've seen.
So thank you again for presenting this very valuable information. Thank you to everyone for attending and participating. I hope everyone has a wonderful weekend, and remember to take care of yourselves. Bye, everyone.
Thank you.